Good morning. I'm really pleased to be here this morning and have an opportunity to share these past couple of days with you all. It's been really a wonderful and invigorating experience for me. I'm one of the people who's been in genetics for quite a while, actually. You've heard from some others as well. But I realized this a few years ago when I started to be invited to give talks on historical perspectives. And the first time I was asked to do that, I thought, you know, historical perspectives are usually talks given by much older people than me. So it was a bit of a shock. And then actually about 2 weeks ago, I was asked to go and do an interview for a nursing journal. And I was meeting the woman who was going to interview me at a Bethesda hotel for lunch, and we were going to do an interview. And I was a few minutes late, and so I went to the concierge and said, I was looking for this person who I was supposed to meet, and he said, "Oh, you're the white-haired woman that she's waiting for." I was a bit taken aback, but my friend, when I told this story, said, "You know, if you were Native American, that would be a real compliment, so having white hair." So anyway, well, I wanted to share with you this morning a little bit about genetic counseling, and I do it with some humility. I have done genetic counseling for 17 years, but in fact, I haven't done genetic counseling for now almost 4 years. I started in genetic counseling in 1976 and worked at the University of Iowa until I went to the NIH in 1993. And now, I guess some people would call me a bureaucrat, which is not necessarily a federal bureaucrat. I actually do manage a grant program called the Ethical, Legal, and Social Implications Program. And I'm, of course, dying to tell you a little bit about the research and education projects that we have going on. So after I talk about genetic counseling, if time permits, I'd be pleased to share with you some of the activities of our branch and let you know what some of our high priority research areas are and some of the other, you heard about some of the policy discussions we've been involved in with regard to genetic discrimination and genetic privacy. But we're funding some really exciting work looking at the impact of genetic testing and counseling for breast, ovarian, and colon cancer risk. We also stimulated the discussion in this country on the issue of informed consent for genetics research using stored tissues, and I'm actually quite excited and proud of some of the work that we've done in this area. I thought I would begin. I was trying to think of whether I should dare to show a couple of joke slides, but I decided I would. I even thought of a joke, but I think I won't tell that. So this is just an old slide that I've had for many years, but this is the geneticist with your surrogate mother. Here's your sperm donor and your father's clone. And this is me holding you when you were just a frozen embryo. That's a bit of a stretch, I recognize, but obviously these are some of the issues that we're here talking about today and in fact, worrying a bit about. One more. Look, lady, you're the one who asked for a famous movie star with dark hair, strong nose, and deep-set eyes. So, if you aren't careful, you might get what you ask for. So I will go ahead then and speak about genetic counseling principles and practice. And I must tell you that there are currently about 1,000, maybe 1,200 genetic counselors in the United States at the present time. That is after training genetic counselors for 25 years. The first genetic counselor training program opened in 1969, graduated its first class in 1971. It's a fairly new profession, and I must tell you, it's a small group of people. And I am one of the genetic counselors in this country who came out of a very quote, non-traditional background. Non-traditional for genetic counseling, not so non-traditional for health professional, health care. We are at a point where I think genetic counseling is going to change. And the kinds of people who do genetic counseling are going to change as well. At the moment, the 1,000 or 1,200 genetic counselors are virtually all women. I can think of 2 or 3 guys, but there may be 10, but certainly fewer than 10. The other thing about the existing genetic counseling profession is that virtually all are Caucasian. And I think that is, in fact, a real problem that we need to address in this country. I think that we're at a point where genetic counseling is moving out of the genetics specialty area. Historically, people who thought about going into genetic counseling are people who did genetic counseling, people like myself. We commonly worked in pediatrics departments. The majority of genetic counselors today work in prenatal settings. But I want you to know that that's going to change. It could be that genetic counselors will continue, a good number will continue in prenatal settings, but a lot of genetic counseling is going to take place in primary care settings. Now, that's a broad, I want to tell you, that's based on my broad definition of genetic counseling. I think we will continue to need genetics specialists, clinical geneticists, genetic counselors, nurses who specialize in genetics. But you must realize that all physicians, all nurses, social workers, other people are increasingly going to be involved in parts of the genetic counseling process. I think a lot of people have an idea that there is something sort of mysterious about this thing called genetic counseling. And I wanted to begin by telling you the actual definition of genetic counseling. If I can get my transparency off my paper. Sorry. This is a multimedia event because I forgot a slide and I this up for a minute. Okay. You've been fairly straight. The term genetic counseling has been around for some time. I think the definition was actually published in 1974. By the way, I guess I should go back a little bit, speaking of historical perspective. I mean, the actual number of human chromosomes was only identified in 1956. So that is in the lifetime of many of us here in this room. The first chromosome abnormality was identified in 1959, and the first genetic counseling clinics began opening in the United States sometime in the sort of late 50s, early 60s. So some genetic counseling went on in the 60s, although it was really limited. The person who recruited me to go and help him in the genetic counseling clinic at the University of Iowa opened the genetics clinic there in 1959. He had a single laboratory technician who in the morning did mouse chromosomes and in the afternoon did human chromosome tests. The early studies were really crude compared to what we are able to do today, but it has been a remarkable shift in the technology in just 30-some years. When I took genetics, I didn't learn about introns and exons. When I started in genetic counseling, we could do a chromosome test, but it wasn't a very good chromosome test. In the 60s, chromosomes, the laboratory test resulted in a dark staining body, so we could tell you if you had an extra chromosome or you were missing a whole chromosome. But it wasn't until the 70s that there was technology where there were light and dark banding patterns, and you could begin to look at smaller and smaller pieces of chromosomes. And then, since the 70s, their technology has evolved to actually look for missing, genes, or a missing sequence of DNA, or an additional sequence of DNA. And the technology, there was a time in the 80s when I thought I couldn't possibly keep up with what was happening. Now I sort of take a step back, and it's true, I still can't keep up with what's happening, but at least I've figured out who to ask, and I hope that's what many of you will figure out, at least in part through this conference. So here is the definition of genetic counseling, and when you read it and think about it, there really isn't anything very mystical. First of all, the first goal of genetic counseling is to help people to, quote, comprehend the medical facts. You remember the presentation the first evening of this conference where Ms. Markey said, "No one told me. I didn't get any information. I didn't understand what hemophilia was." And that is one of the things that geneticists and genetic counselors through the years spent a lot of time just sitting down with the family and saying, your child has disease X, and this is what sort of a typical child with this disease, what you'll see in the future, try to explain the variation. Genetic diseases are commonly, they have long names, mucopolysaccharidosis type 3. And people, many doctors, many nurses, okay, I remember there are mucopolysaccharides, but what does it mean for this child? So that was the first part of the job, was to help people to understand what their children had. And that included not only an hour or two of discussion, but also providing written information to take home. The second part is to help people to understand the genetic contribution. Boy, is that changing. I can tell you that when I started in genetics, we didn't know Prader-Willi syndrome. We figured it probably had some genetic contribution, but we had no idea what it was. And now today, we know what it is. Williams syndrome. There are many, many disorders that we basically didn't know what caused them. They commonly ended up in a genetics clinic because nobody else knew what caused them, and we were sort of the people who were asked to talk to those families who had a rare disorder, whether it was known to be genetic or not. Again, many times the conditions were not thought to be genetic because they didn't, quote, run in a family, and yet now in recent events we find that in fact they are genetic. It's just something commonly that might happen sporadically in a family, pop up new in an egg or a sperm cell that goes to form a particular child. Third, to understand the reproductive risks or understand future health care alternatives was another thing that we spent a lot of time talking with people about. Again, in the early days of genetic counseling, a lot of times we were talking with people who had a child with a birth defect or had a family history, a sibling with a birth defect or genetic disorder, and so they were commonly asking about, well, is this genetic? Might it happen again in our family? And so forth. And very often families had been told it won't happen again, and they come to see us after it happened again. In some cases, we didn't see families until they'd had their third affected child. Finally, in the third affected child, someone would say, maybe that is genetic. Maybe it is. Fourth is to choose the course of action that is best for them, and choose the course of action with regard to follow-up care, with regard to decisions about caring for a child in the home or outside the home, with regard to placing a child in a special school or not, with regard to reproductive decision making. And finally, fifth, we tried to help people make the best possible adjustment. So there's nothing mystical or magical about this definition. And in fact, I suspect that many of you in this room do parts of this every day. The one part that most health professionals and most counselors have not gotten involved in is discussing the genetic piece. But the rest, you all are equally qualified or better qualified than some of us in genetic counseling. So what we need to do is help you all to learn enough about the genetics that you do feel confident to share that information. Because people do want to know, I mean, they comment, what caused this? Could it happen again in our family? Is this something my sister should be worried about? Those are questions that come up. And we can help you to get that information. There are lots of resources available. So I'm going to tell you a little bit about sort of the four components of genetic counseling. And the first thing is to establish a diagnosis. And I will tell you that establishing a diagnosis, I guess I am giving a historical perspective talk here. In the old days, that was not an easy task to establish a diagnosis. And in fact, I must be honest, it's not easy always today. But commonly, the diagnosis was based on clinically what you saw on the outside. Facial features, growth pattern, development pattern. But there commonly was not a test to say, aha, you have this or you don't have this. So we had limited diagnostic capabilities 20 years ago. We had some, and we had some that other health professionals maybe didn't use very much. We had the chromosome test. Now, of course, we're at a point where we have molecular genetic tests. And so I will tell you that I think, in my opinion, it seems to me that in my recent years of doing genetic counseling, we spent a lot more time doing tests, and in my opinion, a bit less time in doing talking. And that, to me, was not always the best situation. So what do we do, though, to try to put the diagnosis together and realize sometimes we were sort of like private investigators. We got information about the family. There might have been some vague family history of a sister's child who died of disease X, but nobody had ever talked about it. And so commonly we were involved in extended family discussions to see if we could get information about that person who had died, an aunt, a cousin, something. We did offer commonly diagnostic tests. We tried always to see the affected person, if at all possible, because what we found was that sometimes people were given a diagnosis that was incorrect. And if you have the incorrect diagnosis to start with, doing genetic counseling is a pretty risky business, because there are some disorders that look like other disorders and the inheritance pattern is quite different. And so it was really important to be sure that you were counseling based on accurate information of diagnosis. So an examination of the affected person. I should actually just mention, I put that slide in, that is my former mentor who recruited me, and that little baby is mine 10 years ago. So family and prenatal history, sometimes you would get a history of something that had gone on during the pregnancy that might explain what was going on in the child. Laboratory tests, x-rays, consultations with other specialists. There might be eye findings or heart findings or kidney findings that when you put all the pieces together, you could determine a pattern. One of the problems in our healthcare system, and I don't know if it's going to get better with managed care, that remains yet to be seen, but one of the problems we saw a lot through the years was there was one doctor looking at the kidneys and one doctor looking at the eyes and one doctor looking at the some other body part, and it wasn't always the case that all of those doctors and the other health professionals that they were working with were talking to one another. So you'd find a patient who had a lot of pieces of information, and nobody had sort of sat down and said, well, this all fits together, and this is how it fits together. As I mentioned earlier, we used to do a lot, in my view, we used to do a lot more talking and a lot less diagnostic tests. This was a typical kind of genetic counseling family that would come in to see us. This is a couple that came in because the young man over here had two siblings that died of cystic fibrosis. And this particular family came in back in the 70s sometime. I don't remember exactly the year. And what could we offer that family? Well, we could do the statistical analysis. There was about Dr. Collins mentioned last night, there was a 2/3 risk that this young man would be a carrier of CF, a 1 in 25 risk that his spouse would be a carrier of CF, a 1 in 4 risk if they were both carriers to have an affected child, and you do the math and you have a 1 in 150 risk to have a baby with cystic fibrosis. So what did we do? So that didn't take long to do that math calculation. We could do that before they came in if we knew for sure those siblings died of CF. So what did we spend our time doing? We spent our time talking to them about their experience, about his experience with CF, how he felt about a 1% risk to have a child with CF. I can tell you that his parents thought a 1% risk was far too high to consider having a child. They had watched 2 children die. It had not been a pleasant death. It had been a very miserable experience for the parents. This young man felt a 1% risk was a risk he was willing to take, and in fact they went on and had several children who were not affected with CF. But in that situation, they decided they had the information, they took the risk, and in their case, they had a happy outcome. Today, this same family comes in. It's different now. Our first goal is to say, well, we need to try to find out whether your siblings had genetic mutations that we can detect. And I will tell you that, Dr. Collins talked a little bit about CF, but over the last 6 years, we've found over 500 different mutations in the CF gene. And most tests that are offered today test for 6 or 12, or in fact, one lab offers a test for 32 of those mutations. Nobody tests for all 500 mutations. It's too expensive to do that. Technologically feasible, but not fiscally feasible, I guess. So the first thing is to try to see if we can get a hold of some tissue of one of those siblings that died. It comes as a shock to many people that in most cases, tissues still exist. Tissues are stored for many, many years in this country in pathology labs. It's very common that we can get a hold of tissues and actually try to do the DNA test. If a mutation can be found in that tissue, then you know that you have a mutation you can test for, and you can give some pretty definitive information to this couple. In some cases, in about 10 or 15% of the cases, the mutation will not be found. And so after getting the tissue, and realize getting the tissue, we can do it, but generally what we need to do is get the parents of the children who died, we have to get their permission. And it tends to cause some upset in a family, because this young couple may not have told their parents they were going in for genetic counseling. They may be afraid to tell their parents because they're afraid that if they tell their parents that they would think about having a test or having prenatal diagnosis, that in some way reflects how they felt about their own life, their life with their sibling. It has a huge impact on the whole family. So you go then, you get the tissues, you run the test, you find something, or you don't find something. And it is, if you don't find something, then we're back to that time of just sort of saying, well, we did the tests, it didn't help, now we're back to the statistics again. So it can be a rewarding experience in terms of getting exact information, and it can be very frustrating for families when you go through the trouble, the sort of upset that can occur in families, and end up not getting the information. So this is sort of an example of how counseling has changed over the years. Informative counseling, again, these are all parts of the process that you all can contribute to. Realize that there's a tremendous amount of information available about genetic disorders today. I urge you all to become aware of resources available. People who have a genetic disorder in their family or who are worried about a genetic disorder in their family, most people do want information. Not all, but most do. They may need to get a little bit of information over time, but usually they want information. There's information on the World Wide Web on just about any topic you can imagine. It's a wonderful resource. I do urge you to be cautious. Some of the information that's on the web may not be the kind of information that you want to share with families. There are genetic support groups, and they have a lot of information about the disorders. There's a group called the Alliance for Genetic Support Groups located in Chevy Chase, Maryland. They are a consortium of some 250 voluntary health organizations, and they have access to lots of information. There are genetics clinics all around this country. Every state has at least one. I can't think of a state that doesn't have one. Some states have one, and that's it, and some states have lots. So it depends on where you're located. There again, in Bethesda, Maryland, there is an American Society of Human Genetics, American College of Medical Genetics. You can call and get the name of the closest geneticist or genetic counselor to you. There's also a National Society of Genetic Counselors, and as mentioned before, the Nurses in Genetics group. Informative counseling, in our opinion, in our philosophy, was that we wanted to not only talk to the patient, but we tried very hard to talk to the family as well. Now, I recognize in some cases individuals want to keep the information private, but we really encouraged individuals to open up and share this information with other people in their family. We were very encouraging of people to bring in other support people. Sometimes people would choose a support person rather than a family member. We certainly were always happy when a member of the clergy would come in and hear the information for themselves. Any health professional can go with the family, and I recognize time is a problem. But if you want to get the information about the disorder or want to get information about the genetics or what to expect, any other members of health profession, members of the clergy, people that the family would like to have with them would be welcome in a genetics clinic. Information, in our view, needed to be practical. Babies born with genetic diseases still needed to, their parents commonly still needed help with feeding. You know, if a baby came in clinic and was, quote, failing to thrive, was the baby failing to thrive because the baby had a genetic condition, or was it because the baby wasn't eating? So you can't focus so much on the genetics of these disorders that you forget that there are some basic needs. Children need to eat, sleep, be warm, be loved. There are other reasons that babies may not thrive besides a genetic disorder. So accurate. People are given lots of information that is not accurate. They're given information from their grandmothers, their wives, old quote-unquote wives' tales out there. Oh, well, this couldn't be from our side of the family, you know. This probably is from your wife's side of the family. And, you know, when many genetic disorders, it takes a mutation from each parent, and it's very difficult when one side of the family says, no way, that didn't come from our side, that had to come from their side of the family. So it needs to be accurate information, it may need to be reinforced, and so forth. They need information about reproductive options. And again, that may not be something that you would want to take up with a couple right away. Most couples who've just had a baby may not be interested in having a baby again in the next short time. It's hard work having a baby. So it may be over time that you talk with them about whether they're thinking about other children. And in some cases, it may be simply saying, you know, there is no increased risk for this to happen again, or it may be you do have an increased risk for this to happen again, and these are some options that are available. Some people will choose to consider reproductive alternatives. Other people will choose to take their chances, say their prayers, and hope that the outcome is a good one for their family. Supportive counseling. Supportive counseling includes helping people to work through the impact of such a diagnosis in the family. And, you know, this particular impact is one that you all are familiar with, the grief process. Even if the child does not die, people do, in general, go through a grief process that resembles death and dying. The denial, the anger, the guilt, and hopefully the resolution of this process. Recognize that it will occur, but as you're recognizing that it may occur, you also, I encourage you to celebrate with the family the life that they have with their child, because many families say, you know, that their friends didn't know what to say to them, so their friends didn't talk to them. And that's the worst, the isolation. If you don't know what to say, you can just be there. You can just be there. You don't have to say anything. And you can take the cue from the family on whether they want you to rejoice with them or whether they want you to be sad with them for the time being. It's important to get people into support services. There are early intervention programs. There are, I mentioned the genetic support groups. There are parent support groups. I urge you to become aware of those kinds of services that are available. I mentioned the reproductive decision making, and the issue of, quote, non-directiveness. I will tell you that the genetic counseling community has adopted a philosophy of doing their best to be non-directive in the area of genetic counseling. I will be honest with you, even though we do our best, I'm not naive enough to think that we have no directiveness in our counseling. Not everyone in the genetic counseling profession agrees with me, but I in fact do believe we have our own set of values, and that does have an impact on the language we use and the information that we convey. And we all do our best not to be non-directive, but I think that we have to recognize that we are not value neutral and have to sort of step back when we think that our values are interfering in decisions that families want to make. There's a long-term impact on people's lives who have genetic disorders, and I would just mention that there are some effects on marriage. Some marriages get stronger. Some marriages go on for years and thrive in a situation where they've had an additional stress placed on their life. Other marriages break up, and that makes it really hard when you have a child who needs special care, a child with disabilities, and only a single parent to take care of the child. So you need to realize that the parents will need a break sometimes. We were talking at lunch yesterday, I think the woman, Ms. Markey, who shared that she felt isolated and it was hard for her to find a babysitter. And I was trying to think, I do understand that there are people who would be very worried to take care of a child with hemophilia. That's a very scary thing, for fear that something would happen on your watch. But you know, maybe there are other things that the church could do for that couple. Perhaps there is someone in the church who could help. I've met some parish nurses here, and so maybe some of the parish nurses would be would be willing to help care for the child so the parents could have a break. But also, if you can't find someone to care for the child, how about taking dinner in on Saturday night? That's something that members of the church that I think could help with and wouldn't necessarily require the care of a child that you may not feel confident or able to do. There are also the worries about financial consideration. We've heard a lot about uninsurability and unemployability, and so I'm not going to go on. But having a child with disability does commonly require extra health care costs, extra educational costs, extra babysitting costs, and so forth. So these are challenges. And I mentioned the sort of alternative care resources. Realize that there's been a situation described called chronic sorrow. Again, many families cope really well with having a child with a disability, but realize that there may be periods of time where the family experiences what might be called a setback, if you will. They may be times, sort of developmental crisis points. You know, they begin to cope with their child at birth who has Down syndrome, and things are going very well, and then all of a sudden your child is invited to a birthday party and he's 2 or 3, and the other children are all walking and running and your child is not. That kind of an event can trigger sort of a renewed grief that usually is temporary, but it can happen. Other times are when all the other kids that are 16 are getting their license to drive the car, and it comes to the parents that their child will never drive a car on their own. Or all the other children are going off to college who are their child's age, and they realize that their child will not be going to college. Maybe leaving home, but maybe not going to college. So some of the expectations and hopes that people have for their children, they now realize that some may not, in fact, be fulfilled. And finally is follow-up counseling. And I think it is important realizing that it takes a lot of time and energy to sort of absorb all of the information that people get. Sometimes people misunderstand. Sometimes it's more information than they can handle. It is vital that people be counseled from time to time to see how things are going. What we saw commonly is for the first few years, I'll take sort of the typical family, if you will, if any family is typical, but sort of the family who has a child with Down syndrome. In the first 2 or 3 years, we used to see those families quite a lot, every 3 or 6 months. And pretty soon we'd schedule a follow-up and they would call and say, you know, if you don't have anything in particular you want to see us for, everything's going fine. And so you see these visits kind of get farther and farther apart because the families are doing okay. And that's the usual situation. They may call you up at some point because something new came up and they want to come back in. But commonly you'll see the sort of ability to deal with all of this improve as time goes on. What time were we supposed to end? Now. Okay, then I'll have to not talk about the LC branch, but what I want to do is just end with one final. I have to only tell you about my own philosophy of genetic counseling, and there may be many other genetic counselors who have the same philosophy that I have, but listening the other night really made me jot down. I realized what the people, the first session, the families were saying were reflecting what I tried to do when I did genetic counseling. Let's see if I can take this over so I can actually. In genetic counseling, what I tried to do was provide information to those who were seeking information. And I think Ms. Markey particularly talked about the need for information and how frustrating it was not to have it. I tried to support individuals in accepting the information. Sometimes it was really bad news, and we had to help them to figure out how to accept it and move forward, integrate the information into their lives, and also try to help them to make complex decisions about future care and about reproduction. Third, I had to try to care for those who had no cure. And even today, with all the advances, many genetic disorders do not have cures. We have much better treatments than we had 20 years ago, but we still have a number of disorders that are pretty dreadful disorders, and they really have no cure. I'll tell you that after 17 years, I did some suffering with those folks I worked with. Certainly not like they were suffering, but I noticed particularly after I'd had my own child that it became increasingly difficult to work with couples who were losing a child, who had lost a child. I particularly remember a family about a year after my own child was born who'd had a child with a spina bifida. Actually, it was an anencephaly, where the brain had not formed, and it was a fatal condition. And they came in for counseling to talk about the risk of it happening again in their family. And this woman walked in with a little white book of pictures. And so we did our counseling. The physician was very focused on, you have a 2 to 3% chance that this will happen again, and you can think about taking folic acid to reduce your risk, and so on and so forth. And at the end, we asked if there were any questions. And I sort of realized this woman was still holding her photo album, and I said, "Did you bring some photos for us to see?" And sure, she had, and she was really anxious to show them to us. And here was her photo album, pictures of her baby in a casket. And there were toys and baby bottles, and I must tell you, that was one of the most difficult sessions that I've ever experienced. I tried to stay with people and pray with people when death was occurring. And through it all, I hope that I helped to lighten people's load and shared their challenges and gave hope. Thanks.